Hola, bienvenidos al octavo congreso de la Asociación Mexicana Hepatopancreatobiliar. Yo soy el doctor José Luis Beristain y a nombre de nuestra asociación es un enorme placer presentar la primera conferencia magistral. El día de hoy tengo el privilegio de presentar al doctor Ian McGilvray. El doctor Ian McGilvray es egresado de la Facultad de Medicina de la Universidad de McGill, realizó estudios de cirugía general en la Universidad de Toronto, junto con un doctorado en biología celular y un fellowship en transplantación y cirugía hepatobiliar en el Hospital General de Toronto. Actualmente es profesor del Departamento de Cirugía en la misma Universidad de Toronto y director de investigación. El Dr. McGilvray es un experto en trasplante hepático y cirugía oncológica hepatobiliar y principalmente un área donde ha tenido mucho desarrollo es la cirugía de resección hepática y pancreática ex vivo e in situ. El día de hoy nos va a platicar sobre el abordaje racional a la resección hepática y consideramos que este es un tema de vital importancia porque comprende varios aspectos como un conocimiento superior de la anatomía, el tener imágenes de excelente calidad, idealmente en tercera dimensión y como lo hacen en Toronto, con animaciones en tercera dimensión preparatorias. Estoy seguro que todos obtendremos consejos muy valiosos de esta conferencia y no me queda más que agradecer y darle la bienvenida al Dr. McGilvray. Adelante, doctor.
So I'd like to thank the organizers for inviting me to give a talk in these strange times. I've been asked to talk about a rational approach to liver resection. So I'm going to spend the next 40 minutes or so presenting an approach to liver resection. And I think the subtext to what I'm going to be saying, the liver is an amazing creature. You can do amazing things with it. But if we get it wrong, then terrible things happen to our patients. So I guess the underlying question in this talk is how far can we go and still be safe? And there are 4 sections to this talk. I want to talk about biology. I want to talk about the fact that surgery is a team sport. Go over some of the technical aspects of liver resection, and then in the end discuss how it is that we assess what is resectable in this age of ever-changing limits. So I'm going to start with biology, and I think ultimately the issue is patient selection. We want to choose the right intervention for the right patient. And when I look at the indications for liver resection, at least cancer indications for liver resection, which is what I'm going to focus on here, in our center, the majority are done for metastatic colon cancer, then hepatocellular cancer, then chlangiocarcinoma, and then a whole bunch of other things, sarcomas, renal cells, melanoma, on and on. And I'm going to focus on 2 just to make a few points, metastatic colon cancer and chlangiocarcinoma. And the points I'm going to make is that the biology of these things changes radically, and I think that should influence how far we push the limits with liver resection. So colorectal cancer, even over a relatively short period of my career, has changed quite radically. It used to be, if you had somebody who had metastatic disease, it was almost game over. Now it's like a whole new world. And it seems pretty clear that liver resection improves survival of metastatic colon cancer, that if you can get a patient to surgery, they do better. And hand in hand with that has been the fact that the chemotherapy for colorectal cancer has improved so much. So the chemotherapy has improved, and I think that's opened the doors to us doing more and more from a liver resection standpoint. So it used to be that we would define what can come out in the liver by what comes out, right lobe, left lobe, segmentectomy. That was pretty easy to define. Now it's much more difficult, frankly, because it's almost a parenchymal sparing technique. In almost all cases, you're trying to save liver, not take it out. And that's reflected in the consensus criteria for resectability, where in essence, when you read these consensus, it says, well, if you can take it out and you can take it out safely, then you probably should. Here's an example of that. So here's a case that we had about 2 years ago. A man who was 56 and had a colon cancer jammed up against all 3 hepatic veins, right up there. And then a number of other lesions in segment 2, segment 3, segment 6. So years ago, this would have been unresectable, but in the current climate, what we did is a partial resection at the very top of the liver, segment 7, 8, and 4A, with a resection and reconstruction of all 3 hepatic veins, flushing the liver with an in situ cold perfusion of the liver, wedge resections of everything else. And that was with the cancer in situ. And then he went on later to have his low anterior resection. and he's done reasonably well since. And I saw him in clinic just 2 weeks ago, which is why I remembered to put this film up. So that's colon cancer, which really is a very good indication for liver resection. I think it's a very good indication for pushing the limits of liver resection. Well, let's talk about something different. So what about chlangiocarcinoma, hyaluronic hepatic? So the classic of these is a Klatskin tumor, tumor at the bifurcation of the bile ducts with a variety of classification systems. But what I wanted to focus on is the fact that while we can resect a Klatskin, I think really the question should we be resecting Klatskins? Because when you look at the 5-year survival, even in large centers, the 5-year survival has probably improved a little bit with ERA, but it's still not grand. I mean, you're still looking at a 25–30% survival at 5 years. And that's putting people through a large operation. And, there's no patient that struggles as much as a Klatskin patient struggles. This is our own data, and we look at, we've sort of adopted, as I think most people have, a sort of more is better approach to surgery for bile duct cancers. And clearly ERA improves survival, as you might expect. If you do a liver resection in association with a bile duct, survival improves. I think that would be expected. The more liver you take out, the survival seems to improve as well. I think that's because you have skip lesions along the bile duct, and you get a better negative margin if you take more of the duct and more of the liver. Margin status clearly impacts survival. Nodal status probably impacts survival, but well, definitely impacts survival, but how much is another question. And what about vascular structures? What about if you have a Klatskin or cholangiocarcinoma that's involving an artery or a vein? So there's a pile of literature out there. I think the bottom line is that artery resection may be worse than portal vein resection from the standpoint of how people do in the long term. Adding a Whipple procedure to a liver resection is bad, and probably experience counts. There are center-specific results for this. So in general, with the proximal cholangiocarcinoma, the world has moved towards a more radical surgical approach, and that has improved the R0 resection rate. It means you can resect more advanced tumors. There's probably some impact on overall survival, disease-free survival, but I think there's certainly room for improvement. And I think the distinction here is that unlike metastatic colon cancer, there's no good chemotherapy for cholangiocarcinoma. That may be changing. That may just have changed in the last few years because there's some groups who become much more aggressive when it comes to chemotherapy for Klatsins. And I think targeted treatments show some real promise. But it just points out that cancer, and cholangiocarcinoma in particular, is a systemic disease. And the rates of recurrence, well, they're usually systemic. They're usually in sites distant from the liver, and liver surgery is a local treatment. So there's a limit to what you can expect from it. This is an example of this. This is our own data with liver resections that are done in association with exclusion of the liver and vascular reconstruction for a variety of indications. And I'm only pointing this out because this is, if you like, the more extreme approach to surgery in the liver. And you can see in the top panel that the overall survival for all comers is about 40% at 5 years. It's actually people who have metastatic colon cancer and have these extreme surgeries, it's actually do remarkably well. The 5-year survival can be out near 60%. But by contrast, people with cholangiocarcinomas don't. So the 5-year survival is few, and the 3-year survival is only about 30%. And it just points out the difference in biology, that you can do wild and wonderful things to the liver, but in the end, biology trumps everything. So as a summary, you can do amazing things to the liver, but I think you need to ask, should you? And biology trumps everything. Cancer is a systemic disease, and I think it makes the most sense to push limits when surgery is not the only choice, and chemotherapy is a good thing. Second thing I want to talk about in terms of approaching liver resection is to point out that liver surgery is not a surgeon-specific event. We tend to think of surgery surgeons, but even in the room, there's so many other people who are important to the operation. Anesthesia, 1 or 2 people there, maybe a fellow, our nurses, scrub and circulating, trainees, residents, fellows, X-ray staff, even the people who are helping move patients in, patients out. And that doesn't say anything to everyone else once you get out of the OR, like the nursing staff, the expertise of the floor, the ICU, and all of that's really important for how well our patients do. And it's also really important for how we start to think about what we should be doing for a liver resection. And it brings up some interesting points, because all those people, all those different specialties are going to look at a patient and a case differently, even among the same specialty. So this is a picture that I took a couple of years ago of staff surgeons and a staff radiologist staring at the film of a case that they're undertaking. And in that room, you have a staff, you have a fellow, you have a senior resident, junior resident, the staff radiologist, somebody else. And everyone is looking at that CT on the screen, and everyone is seeing something slightly different. Even though everyone is an MD and everyone, in theory, knows what's going on, but everyone's seeing that somewhat differently. So your ability to conceive of how you're going to do the operation or how you're going to carry it out is going to be seen very differently as well by all those different people. So one thing we found very useful to bring all these disparate specialties together, to put people on the same page, is to create a page, is to create a script. Because if you tell a story, then people immediately become involved in that story, and they take ownership in the case, whereas before they might just have been doing a job. And the script is actually quite useful for many reasons. One is that it helps you think what you need for the case, both for the physical things that you need, the retractors, the high energy devices, on and on. And also it lets you start to introduce the case to anesthesia and to everyone else in the room. Like, where do I want the line to be, right or left? Do I want a TEE? Do I need someone else in the room? And the really useful thing, I think, for this is that it lets you plan backups. It lets you plan escape routes. You can think, well, if this goes wrong, then what else do I do? And you've thought about it beforehand, so the whole thing goes more smoothly. And you can take this to long links. This is an example of a 25-hour-long case in the script that we made for it. I thought it'd take 25 hours. It took 25 hours. There were 45 steps in it. But anesthesia was there for the full 25 hours. Everyone stuck it out, and the patient did great. And the other thing about this is, I think, if everyone's on the same page, if you go off script, it makes it easier. So here's a intercable sarcoma that starts at the bottom, grows into the right hepatic vein, and then grew up and was pushing into the atrium. So what we planned on doing is taking out the posterior aspect of the liver, the kidney, rebuild the cava, and then reimplant the middle and left hepatic vein. That was our plan anyway. We knew that the right hepatic vein was going to be obstructed by the tumor. This is the TEE demonstrating that, the really sluggish flow in the right hepatic vein. What we didn't anticipate was that in the time it took to get the patient to surgery, the middle and the left hepatic vein had clotted off. So then we were in this really awkward position where we had to decide, what are we going to do? Are we going to abort, or are we going to abandon our planned in situ approach and then take it to the next level and do an ex vivo approach? And it was a difficult discussion, but in the end, we decided to go with an ex vivo approach. And so we took the liver out with the specimen, found the hepatic veins in the liver, pulled the clot out, hoping that we could get enough that we could unblock the liver. That's the specimen, the caval tumor. And then on the back bench, in a very controlled way, you can divide the liver. That's the caval graft that we use, and this is us cutting a diamond-shaped hole out of the front of the graft to sew the liver graft into. The liver going back in, and that's the pre-shot of the sarcoma in the right atrium, and the post-shot with the atrium free of tumor. That was 6 years ago now, and that patient did very well. And the thing about the script was that, and the thing about the fact that everyone knew what was going on, was that we could change gears really quite quickly intraoperatively. And I just wanted to spend a few minutes just talking about anesthesia. So, anesthesia is really critical for all these cases. You can't have a decent liver resection without a decent liver anesthetist. In every case, whether it's a liver transplant or whether it's a routine liver resection or whether it's a wild and wonderful liver resection with clamps and exclusion and flushing, and they all have different phases, and every phase is slightly different. For the clamps, there's the pre-clamp phase, the phase when you put the clamps on, and then when you've taken the clamps off, and they're all different. In the pre-clamp phase, for instance, you want to keep the CVP low. This is true of any liver resection, keep the CVP low, but there's no target about that. It's just a relative thing. And I really do think we should be using cell salvage more than we do. I think the dogma that cell salvage is bad and will spread cancer is a bit silly in an age when we understand that cancer is a systemic illness to start off with. Stuart McCluskey, who made these slides for me, I referenced at the bottom. He's a good friend and an excellent anesthetist, and he makes a point of coming into virtually every difficult liver case and just checking in with the anesthetist who's there and making sure that everyone understands what should be going. And there's a lot of preparation involved here. This is a picture of me about 2 years ago. I don't really like that picture. It was before I went on a diet. But this is just to point out that there's a lot involved in the preparation for a patient. The IV, pulse ox, defib pads, difficult art lines, the central line, the swan if it's a really tough case, rapid infuser, you need the pump set up, maybe not cyclocapron, vasopressin, levofed. You need to have that set up and ready to roll so that if you have any problems, off you go. And one of the things I wanted to point out, and we'll come back to later, is that you're never really sure what you're going to get into with really extended, if you like, indications, extended cases. And although most people will tolerate a cable clamp pretty well, some people don't, and you may be forced to put somebody on veno-veno bypass, and just doing a fast digital cross clamp to test whether you can get a patient through a cross clamp is very useful. When the clamps are on, when you're in an anhepatic phase, then fluid management becomes as important as at any other time. Really, you should keep it as limited as possible. You really got to watch the coagulation. We found the Rotem to be a very useful thing there. And inotropes. Now this I'm just pointing out for a reason. So one of the reasons we got into the extended liver resection game, if you like, is because we have a large center from the standpoint of live donor liver transplants, large from a Western standpoint anyway. And whenever you have a liver that's excluded, whenever you have a liver that's clamped off, you can't simply remove those clamps. You have to be very cautious when you do it, and you have to do it gradually. And again, just taking your hand and slowly releasing pressure while you watch the monitor and while you watch what's happening with the patient is a very useful thing. So second summary, so surgery is not just surgeons, it's a team sport. I think you have to talk to your anesthetists, says Uncle Stuart, and you have to have backup plans like the veno-veno bypass if needed. Difficult cases really need to be planned. And we have personally found, script a very useful thing for bringing different groups together and focusing people on the operation. So now I want to move to talking about some technical aspects of liver resection. So what is it that makes a successful liver resection? Well, it's not rocket science. You need to have decent inflow. You need to have decent outflow, hepatic veins in the cava. And you have to have an adequate residual liver volume. And how much of that varies with the quality of the liver parenchyma. Decent inflow. So there are three sources of inflow: the hepatic artery, the portal vein, and the bile duct. And they all carry oxygenated blood to the liver. And there are a variety of options for dealing with all these things. So the hepatic artery, one thing that's useful is to always make sure the celiac orifice is open, and if it's not, then stent it pre-op or balloon it up. In terms of replacing the hepatic artery, I think the saphenous is a great tool. And it's also remarkable that once you've mobilized the celiac, how much of a segmental resection of the artery you can do and still bring the ends together. In terms of takeoffs for an interposition graft, the aorta is always useful. The renal artery is particularly useful if the aorta is calcified or atherosclerotic. Sphenomesenteric artery is something as a fail-safe. The gastroepiploic artery as a pedicle graft can get you out of trouble. It's small, but it works. And swinging the splenic artery over can sometimes help, but that's more for a transplant. For the portal vein, again, there are multiple graft options here too. The left renal vein is a good size, but it's short. The superficial femoral vein is amazing as a replacement for the portal vein. It's about the same size, and you can get almost unlimited length. The jugular vein is something that I used to use, but I don't use much anymore. There is a certain rate of thrombosis, central cerebral thrombosis afterwards, and I'm not sure it's worth the risk. Biologic grafts are a possibility. Core matrix or bovine pericardium both work well. And of course, artificial Dacron sews beautifully in PTFE, has a nice, ring PTFE in particular has a great patency rate. I think it's worth mentioning that bile duct can supply a surprising amount of oxygenated blood to the liver. And so I think whenever possible, we should be trying to preserve it. It can be a struggle to do that, but I've had a number of cases now where I've left the bile duct intact and had to reconstruct the portal vein for whatever reason, and the portal vein went down, but the liver was fine because it was getting blood through the bile duct. And it's amazing how over time the liver can completely re-arterialize itself through the bile duct, even through an hepaticojejunostomy. It's an amazing thing. This is, I think, maybe my favorite topic, is dealing with outflow, hepatic vein management. And liver surgery gets tricky when the major vessels that you want to keep are involved, particularly if you have a tumor that's up near the outflow tracts of the liver, the left hepatic, the middle hepatic, right hepatic vein. And dealing with that is difficult because ideally, to deal with it, you have to establish a bloodless field. You have to exclude the liver. And as soon as you do that, you can do some element of hepatic ischemia. And then when you release the clamps and the liver is reoxygenated, you get ischemia or perfusion injury. Now, the liver tolerates that remarkably well. Whether the surgeon tolerates it is another issue. It's nerve-wracking, I find, to have the liver excluded for that long and the clock ticking away in awkward anastomoses. So ideally, you want a technique that will maintain parenchymal integrity and surgeon calmness for as long as possible. And one solution to that is to adopt transplantation techniques for oncologic liver resections. And live liver transplantation is really very analogous to every step of a difficult liver resection. The resection portion, the preservation section where the graft is placed on ice, and then the implant section. And that leads very naturally to in vivo in situ hypothermic perfusion, which is a technique where a cannula is placed into the portal vein or artery, but I think the portal vein is safer. And the liver can then be excluded, and through the portal vein cannula, you can flush the remaining liver with ice cold preservation solution, whether that's UW or whether it's HDK or whatever you use. And it cools the liver really quickly. You can pack the liver on ice to help with that, but the flush is often enough. And it makes it safe. And you can keep a liver like that for 2 hours, probably longer. And it's remarkably well tolerated. And that gives you time to do things like sew in your cable graft and reimplant hepatic veins. Here's an example of this. This is an hepatic vein reconstruction that we did maybe a year ago. No, I take it back 2 years ago. It's a man who is 49. I apologize for graphics. We made this for this meeting. He'd had a prior right hepatectomy with caudate for metastatic colon cancer, but was left with a number of lesions in the residual liver. 3 lesions in segment 2 jammed up against the portal vein, a lesion in segment 4A, and another one in 4B. The one in 4A was really jammed up against the middle hepatic vein, which was one of the principal drainage sites for this remnant liver. And this is just pointing out that the segment 2 portal vein is quite close to the tumor, but the left hepatic vein is free. So our plan was to resect segment 2, but preserve as much inflow to the remnant left side. We used a Pringle maneuver for the sake of minimizing blood loss during that portion of the operation. And then we moved to the other side. The plan is to do a wedge resection of segment 4B, that small lesion, and then move to the tumor that's on top on the middle hepatic vein and remove that with the middle hepatic vein, and then replace the middle hepatic vein with a graft while flushing the liver and keeping it cool, as I just described. This is the operation itself. So this is the segment 2 resection. I'll take it back, actually, it's the segment 3 resection. I just realized my guys mislabeled that. Anyway, this is the wedge resection of segment 4B. And then we move to the top, make a graft out of bovine pericardium. It's a very nice little tool because you can make it to any diameter that you want, and any length really that you want. So that's the graft. Then we resect the top portion of the liver, which has the tumor in the middle hepatic vein, flush the liver. This is us cutting the middle hepatic vein outside that liver, and this is cutting the middle hepatic vein inside the remnant liver. And this is us starting with the graft. So the graft is parachuted down to the middle hepatic vein orifice, and then sewn into the middle hepatic vein orifice on the liver side. And then we release the clamps to flush the liver of the perfusion fluid, flush it through the upper anastomosis in this case. And that's the completed graft. So that was 2 years ago. He's done really very well, this man. This is just another example. I keep bringing up veno bypass, and the previous fellow that I showed you tolerated the clamp perfectly well. Not everyone does, especially when your liver is completely normal. This is a 60-year-old who had a huge hepatoma that probably grew from adenoma because the liver itself was completely non-cirrhotic. It involved most of the right side of the liver, and it had grown up into the cave and had grown up into the lower part of the heart. And this patient did not tolerate clamping, so we instituted vena bypass with a cannula in the cava going up to the right jugular, and then flush the liver, with the plan being to divide the left hepatic vein within the liver, clamping the infrahepatic and the suprahepatic cava above the tumor. You can get a clamp very high atrium, as long as you avoid the coronary sinus. Start the vena bypass, and then put the cable graft in and sew the liver back to that. So that's, these are extensive cases. In situ cold perfusion of the liver is an extensive case. How well do people do? There was a review in Annals of Surgery in 2015 from Daniel Azoulay's group. From 1970 to 2012, 205 cases published, 23 deaths. This is Dr. Azoulay study. This is one of our earlier ones. If you look at Dr. Azoulay study, which is the largest at the time, 77 patients, total vascular exclusion, in situ perfusion. Only 33 actually in the end required a vascular reconstruction. They have a different approach to it than we do. About a 19% mortality over 90 days and fairly morbid procedures. This is our own data. When we look at 2006 through 2018, there were 56 cases of in situ or ex vivo, all of which have had vascular reconstruction, all of which are similar to the cases that I showed you on those videos. Most of them are metastatic colon cancer, then chlangiocarcinoma, and then the rest are sarcomas, hepatomas, and a variety of other things. If you restrict the analysis of 2006 to 2016, where we have a long follow-up, that's 43 patients. They're long cases, take about 10 hours. Almost everyone is transfused, probably not surprisingly. Mortality, 90-day mortality is about 12%. Still quite a morbid thing, 51% grade 3 or higher morbidity. It does seem to be a bit of a learning curve, and that the length of stay in the ICU steady decreases with more experience, which would be anticipated, of course. Okay, so I did want to touch on what is a functional liver remnant. So from everything up till now, you can do wild and wonderful things to the liver, but you only get away with it if the liver that you leave behind kicks in and works. And if it does, then the patients do spectacularly well and can be out of the hospital in 5 days. And if they don't, then it's terrible. So you really need to spend a lot of time thinking about what that liver that you leave behind is going to do. How much do you need to leave behind? Well, if it's normal liver, probably 20%. If it's fatty, probably 30%. If it's cholestatic or cirrhotic, at least 40%. But there are going to be some livers that you need more, and some livers probably that you can get away with less. And it's hard to predict which those are. And if you're doing one of these wild and wonderful vascular reconstructions, how much liver should you leave behind arbitrarily? Probably about 40%. And if you do have a small remnant, what can you do? Well, there are modifiable patient factors, dealing with sepsis, getting the patient in an optimal shape. dealing with everything else around the liver, giving the liver time to grow, supporting it. From a liver standpoint, if you've got a steatotic liver, then putting a patient on Optifast or some sort of bariatric diet is not a bad thing. Drain the duct, hold the chemo, be very careful with surgery, good technique. Growing the residual liver is an option. Portal vein embolization is used a lot. 3 questions: how effective is it? Well, I think the standard of care is to put a plug into the portal vein, then backfill it with glue. And N-butyl cyanoacrylate, I can barely say it, probably gives you the best results. What kind of results? Probably about 50% growth on average, you can anticipate. Is there an effective chemotherapy? Not really. Does underlying liver disease affect the results? A little bit, but not too much. So overall, portal vein embolization is reasonably well studied. You can expect about a 50% increase in the size of the residual liver. Chemo is okay, and still effective, though less so if you've got liver fibrosis. Here's another approach. If you have a small FLR, staged resection, complete resection of colorectal mets in 2 successive operations. It's well accepted, and generally what you're trying to do is clear one side, 4A, 4B, and 1, clear segments 2, 3, embolize the right portal vein, and induce hypertrophy of segment 4A, B, and 1, and then do a right hepatectomy, is the idea. Does it work? Yeah, it does work. My feeling about it has changed a little bit. This is a case from Clinical Oncology 2011, 65 patients who had the first stage of a stage resection, 18 patients did not get the second for a variety of reasons, tumor progression or inadequate response to PVE. If you look at that a little bit more closely, the tumor progression in 62%, it's going to be 2 things. It's either going to be increased size of the existing mets, which you can live with, or it's going to be increased number of mets. Now that's a different thing. I think that portends bad biology. So I think you can take that as an indication of somebody who probably shouldn't have had a second stage in the first place. So stage resection, certainly applicable to a good subset of patients, decent 5-year survival, often relies on having segments 1 and 4 free. At least 1 of 4 patients will only have the first stage, and this isn't necessarily a bad thing. Having said that, there's some recent data with the ALPS procedure that will point out, and change my mind about that, change our mind. So the ALPS procedure, I don't need to describe it, everyone knows about it. Does it work? Yeah, variably, but yes, it works. And this is the LIGO study, which is a randomized trial comparing stage resection to an ALPS procedure. And interestingly enough, in their interim analysis, they found that ALPS seems to improve survival in patients with colorectal cancer and a small functional remnant more than the staged hepatectomy. This is the graph that shows that. I mean, I think the curves eventually converge, but certainly you do seem to buy a survival advantage. And that probably speaks to the fact that you're getting more people to surgery, getting more people through surgery, that there is a survival advantage to debulking, if you like, in colorectal cancer. So ALPS has definite advantages over PVE, shorter interval between procedures. You're not reliant on interventional radiology. The second operation is smaller, but it still isn't terribly well standardized. There's still bioleaks, sepsis, the liver can melt, and there's no interval for oncologic reassessment, if you like. But overall, not a bad technique, especially for metastatic colon cancer. So summary of the technical aspects, planning and executing the resection. I think you really need to have a careful preoperative assessment of the functional liver remnant, liver function. You really need a careful plan of the intraoperative approach, including the vascular involvement and how you're going to deal with that. Very careful execution, minimizing ischemic perfusion injury as much as possible. And if you have small for size, you should consider portal inflow modulation. I didn't talk much about that, but there is evidence on small animals, certainly, that portal inflow modulation with things like octreotide can help. There are some interesting studies looking at stem cells, actually, to induce regeneration. There are things we apply in living donation all the time, like splenectomies and whatnot, to try to decrease the portal flow. And I think we should be thinking more about those things in liver resections. Last part of the talk, I wanted to talk about how we assess resectability, because this is something of a moving target. And, I think we all need to talk more about what is resectable, what isn't resectable, because in the end, we all are trying to do the best for our patients. So what defines resectability? Well, everything we talked about so far. Hepatic issues, you have to have adequate inflow, adequate outflow, an adequate functional liver. And of course, that varies with the patient with the liver. And then there are oncologic issues, obviously, R0 versus non-R0 resection. Obviously, you want a R0 resection. Whether there's vascular involvement and how you can deal with that or should deal with that, whether there's biliary plate involvement or the implications there. But this is an example of what you get. So here's a case of a colorectal met that's jammed up against all three hepatic veins. Now this is, again, this is eye of the beholder type situation where you could very reasonably say this patient is unresectable, or you could look at this and say this is the most straightforward in situ hypothermic perfusion setup there is. And it's ideally what we'd like to do is be able to discuss cases like this in an open forum, but that's complicated because of everything I talked about before. Everyone's looking at these cases slightly differently. Everyone has a slightly different experience, and it's hard to get people all on the same page. And looking at a CAT scan, even, people are seeing different things. They're not seeing necessarily what other people are seeing. It's interpretation is everything to this, and that's hard because people come at it with different experiences and different backgrounds. One of the really interesting tools I think that come out in the last couple of years is virtual reality, and I think that has, oddly enough, some promise for dealing with issues of resectability. I'll show you what I mean. So we've been playing around with modeling. This is a small child's cranium. I'm only showing this because I thought it was kind of cool. I'll show you later what you can do with the liver, but this points out that you can put an anatomical model into the virtual space, and then you can start playing with it. You can start moving the coronal planes, you can start moving the sagittal planes, and you can see the intersection between these different planes in a way that you can't with the CT. And with that, you can then start pointing things out. You can say, aha, this is what I'm looking at right here. Now, you could be doing this in wherever. I mean, you could be doing this in any city in the world, and people from any other place in the world could be looking at the same thing, and you can have a discussion with a model, and everyone sees that model, and you can point out exactly what you want within that model. So I think it's a decent forum for starting to talk about this. So we tried this with the liver as well. So this is one of our past fellows, Dr. Lawrence Law, who is sitting in my remarkably messy office, but this is just a demonstration of what you can do from a liver standpoint. So he's looking at he's in a virtual space. This is what he's seeing. 2D representation, of course, he's seeing in 3D. This is, and he's got a model. He can manipulate the model. He can move it. He can start playing with the sagittal plane. There's a large tumor in the right upper quadrant. He can look at it any which way he wants. He can look at the venous phase. Arterial phase. Change that around and look at the other phase. See all the anatomical relationships. Sorry, forgive me, that was the venous phase. This is the arterial phase. And again, you can use the same kind of tools that I was pointing out before. You can take pointers and you can show precisely what you are looking at. And it's a very non-confrontational space, the virtual reality space, and it's it has real promise, I think, for letting us talk about these things anywhere. So this this is an example. We did this. So here's a fellow, one of my fellows, Chris Schubert, is now down at Hopkins. He's standing in Toronto. I'm just going to pause this for a second. This other fellow over here is in a multidisciplinary cancer conference in Dublin, in Ireland. And Chris, our fellow, is showing one case, and the fellow in Dublin is showing another case, but they're both interacting in the same world, and they're talking about the case in real time. And they're both looking at the same model. So here's Chris showing this model. This is a sarcoma that had grown up from the ovary and up through the liver and blocked the liver with a Budd-Chiari. But he can point out the aspects of it. He can point out the plan. The other fellow can now look at it. They can pass instruments around. They can point out exactly what they think is relevant or what is not relevant. And then once they talk about one model, they can go on and talk about the next. So, again, this is across the Atlantic. It works surprisingly well. And it's the sort of thing that we want to push in the future is establishing multidisciplinary clinics across any distance, and specifically to talk about difficult cases and liver resections in particular. So, summary resectability. I think resectability relies on everything else that we talked about: the biology, the team, technical considerations, and beyond that, as a tool of getting around different interpretations of the liver. I think modeling of the liver and virtual reality tools will allow HPB as a field to rapidly discuss cases across centers and across borders. So I'm running out of time, but I do want to talk briefly about some conclusions. So what is a rational approach to liver resection? So again, liver, amazing organ, tolerates a lot, but you get it wrong and the consequences are just terrible. What is a rational approach to liver resection? Well, biology trumps everything else. The patient will do as well as the disease allows and as the liver allows. Surgery is a team event. It's not just the surgeon, it's the anesthetists, it's the fellows, it's the trainees, it's the ICU, it's the step downs, the nursing team. Careful planning is really, really critical. I think, particularly from a technical aspect, having backups, having a plan, scripting the case makes a good deal of sense. And I think we all should be discussing cases more often. And virtual reality and the tools of anatomic modeling that are available now offers one way to do that. So I'm going to stop there, and I thank you for your attention.